Finals SAQ85 Pediatric Airway. A. List the normal anatomical features of young children less than 3 years old which may adversely affect upper airway management. B. Which airway problems may occur due to these anatomical features? C. Outline how these problems are overcome in clinical practice. Anatomical feature: large head with prominent occiput. Problem: tendency to flex the neck. Overcome by neutral position with, for example, folded towel under the body. Next, large tongue with pliant submental tissues. Problem: obstruction of airway by digital pressure. This is overcome by ensuring fingers are applied to bony surfaces. Absence of teeth leads to difficulty in maintaining face mask ventilation. This is overcome by use of appropriately sized gilded airway. Next anatomical feature is long U-shaped epiglottis and anterior larynx. This leads to difficulty with laryngoscopy. Epiglottis flopping into visual field. This is overcome by using a straight blade. Due to narrow trachea, as flow is proportional to radius to the power of 4, small differences in radius due to trauma or edema make substantial differences to flow. This is overcome by careful handling of the airway, selection of appropriate tube size, to minimize the need for changes in endotracheal tube. Airway is narrowest at the level of the cricoid, not the vocal cords. As the cricoid is a complete ring of non-compliant cartilage, hence pressure of the tube may cause tissue damage. With uncuffed tubes, a leak should be ascertained. High volume, low pressure cuffed tubes are now used routinely except in neonates. Next anatomical feature is short trachea. There is risk of endobronchial intubation. Ensure equal air entry on auscultation bilaterally. Ensure vigilance to monitor for endobronchial intubation. 65.4% pass rate. According to Pawa et al., factors adversely affecting pediatric airway management includes anatomical factors and issues with resources. Anatomical factors includes large occiput, long omega-shaped epiglottis, vocal cords that are angled more anteriorly, decreased subglottic diameter and stenosis, larger percentage of narrowing of airway with same degree of edema, cone-shaped cephalad larynx, and comorbidities encountered in the pediatric group, such as Pierre-Robin sequence and Down syndrome. Issues with resources includes burden of stocking different size airway equipment, scarcity of highly specialized airway experts in this age group. According to Wallace et al., risk factors for difficult pediatric airway includes ASA 3 to 4, Malampati 3 to 4, low BMI, children undergoing cardiac surgery or maxillofacial surgery, children during their first year of life, and syndromal children. Compare and contrast lung function in a neonate with that of an adult. Differences in anatomy may be divided into that of the upper airways, lower airways, chest wall, and respiratory muscle type. Upper airways. Narrow upper airways, narrow nasal passages, large tongue and narrow pharynx, clinical implication, increased resistance, provision of autopede, and any obstruction is dangerous. Obligate nose breather due to big tongue and high laryngeal inlet. Any obstruction is dangerous. Prominent occiput. There is tendency for flexion leading to obstruction. There is no need for pillow under the head for back mask ventilation or intubation. Regarding lower airways, there are narrower lower airways, narrower larynx, trachea, and bronchi, narrowest point at cricoid ring compared to glottis in adult. Any obstruction is dangerous. Consider use of uncuffed endotracheal tube. Epiglottis long, U-shaped and floppy. Use straight blade. Laryngeal inlet is higher, C3 to C4 and anterior. Different intubation mechanics apply. Short trachea increases the risk of endobronchial intubation. Regarding chest wall, horizontal cartilaginous ribs reduces outward recoil, reduces bucket handle motion, reduces AP and lateral expansion. Clinical implication: almost all diaphragmatic breathing. Abdominal constriction is dangerous. There is increased airway collapse in expiration. FRC is lower than closing capacity. Regarding respiratory muscle, there are less type 1 fibers, hence reduced reserve and increased risk of type 2 respiratory failure. Regarding lung volumes, tidal volume is 7 mL per kg in both adult and neonates. Dead space volume is 2.2 mL per kg in both. FRC 30 mL per kg supine in both. However, FRC is less than closing capacity in neonates, and FRC reduces dramatically under GA due to muscle relaxation and reduced outward recoil. There is risk of gas trapping and rapid desaturation, also contributed by increased metabolism. FVC cannot be accurately measured in the neonate, unlike the adult. TLC is 50 ml per kg in neonate compared to 70 ml per kg in adults. Regarding resistance and compliance, static compliance is 1.5 to 6 ml per cm H2O in neonates, but 100 ml per cm H2O in adults. Specific lung compliance, no difference. Chest wall compliance, higher in adults. Neonate has lower dynamic compliance than adults. There is increased airway resistance in neonates. Specific compliance is the same in neonates and adults. To reduce work of breathing, neonates have higher respiratory rate, as resistance is a bit higher and compliance is a lot lower. Ventilation and perfusion. Respiratory rate is 12 in adults and 40 in neonates normally. Tidal volume is 5 to 8 ml per kg for both. Implication, there is reduced reserve for increased respiratory rate. Minute ventilation is 220 ml per kg per minute in neonate, compared to 110 ml per kg per minute in adults. Alveolar ventilation is 140 ml per kg per minute in neonates compared to 70 ml per kg per minute in adults. This is due to 2 times increase in VO2 in the neonates, 7 to 8 ml per kg per minute compared to 3.5 ml per kg per minute in adults. Implication, increased work of breathing. Neonatal cardiac output is double that of adults at 140 ml per kg per minute. Implication, increased pulmonary blood flow. Regarding gas exchange, oxygen consumption is double in neonates compared to adults. Implication, rapid desaturation in apneic neonates. PaO2 is 50 to 70 mmHg in neonates compared to 100 mmHg in adults. Due to increased VQ mismatch and right to left shunt in neonates compared to adults. Implication, reduced CaO2 and reduced reserve in illness such as pneumonia. There is increased oxygen carrying capacity in neonates compared to adults. Due to higher hemoglobin concentration, 17 to 18 grams per dl in neonates compared to 13 grams per dl in adults. The P50 of HbF is lower than HbA, 19 versus 27 mmHg. This partially offsets reduced PaO2 such that CaO2 is 16 ml per 100 ml compared to 20 ml per 100 ml when comparing neonates to adults. There is increased blood viscosity, hence increased afterload. Regarding control of ventilation, immature respiratory center in neonates, which is depressed by hypothermia and certain anesthetic agents, lead to frequent mild apneas and frequent apnea postoperatively. Regarding acid-base balance in neonate, CO2 to minute ventilation response curve is left shifted. There is compensated respiratory alkalosis. There is reduced reserve for increased ventilation. Other features in neonates. Neonate-specific oxygen toxicity includes retinopathy of prematurity, bronchopulmonary dysplasia, and necrotizing enterocolitis. Regarding non-respiratory functions of the lung, innate immunity such as mucociliary escalator is present in the neonates and adults. Adaptive immunity is passive from breast milk in neonates compared to endogenous in adults. Regarding response to stress, reduced PaO2, increased PaCO2, and acidosis increases pulmonary vascular resistance, increasing the risk of reversion to fetal circulation and hypoxia. Main reference for this section is from Ketamine Nightmares, ANZCA 2013. Next, we move on to Pediatric Airway Management Principles. Main reference, WFSA. First step is assessment for anticipation of difficult airway. Preparation, difficult airway trolley and other emergency intubating equipment. Surgeon and surgical equipment available if difficult airway is anticipated. Pre-induction, apply standard monitors, IV access when possible, optimize positioning. Pre-oxygenation, adequate mask size and fit, 100% FiO2 for 3 to 5 minutes prior to intubation. Induction, paralysis may be employed, maintain adequate depth of anesthesia. Ventilation and oxygenation, optimize ventilation with positioning. Maintain passive oxygenation whenever possible. Avoid gastric distension. Intubation, improve view of vocal cords with external laryngeal manipulation, select appropriate laryngoscopy blade, size appropriate ETT advancement, malleable airway stylet as needed for assistance, avoid trauma from airway stylet, confirm correct endotracheal placement, failed intubation, limit the number of intubation attempts to 2, changing the technique or provider during each attempt, and calling for help. AAGBI, Polish and AIDAA guidelines recommend maximum of 3 intubation attempts. Consider different equipment such as video laryngoscopy, different laryngoscopy blade. Exercise great caution when blindly introducing intubation aids such as bougies into the trachea. Visualize vocal cords as much as possible. Regarding supraglottic airway devices, select appropriate size and feature, for example gastric drainage. Consider as intubating conduit if intubation is desired. If intubation, confirm with fiber optic scope position. Surgical airway options includes tracheostomy and cricothyroidotomy. Incidence of difficult pediatric airway, which are unanticipated, is 23.8%, and this incidence increases in pediatric patients less than 1 year of age. Differences between pediatric and adult difficult airway algorithms includes number 1, greater emphasis being placed on constant maintenance of oxygenation, which is a key factor in preventing rapid hypoxia, bradycardia, and cardiopulmonary arrest. Number 2, switching to the most experienced pediatric anesthesia provider after a failed intubation to reduce potential airway trauma, airway edema, which can result in significant obstruction in smaller airways. Number 3, different surgical airway pathways determined by age. For example, according to the AIDAA guidelines, which consists of Step 1, laryngoscopy and tracheal intubation, Step 2, insertion of SAD to maintain oxygenation should failed intubation occur, Step 3, rescue face mask ventilation if failed ventilation through SAD, and Step 4, emergency surgical airway access for children less than 8 years. If surgical help is available, proceed with tracheostomy. If surgical help unavailable, if less than 5 years old, proceed with transtracheal needle puncture. 5 to 7 years old, proceed with needle cricothyroidotomy. For children 8 years or more, proceed with needle cricothyroidotomy, jet ventilation. Next, we move on to difficult airway trolley contents. Main reference WFSA, top of trolley, flexible intubating fiber scope. Shelf 1, fiber optic adjuvant tools. Side of trolley, bougies, intubation catheter, airway exchange catheter, and attached documentation. Drawer 1, Plan A, intubation. Include shoulder roll, Magill forceps, different laryngoscopes, video laryngoscope, alternative laryngoscopes, and nasal cannula. Drawer 2, Plan B, oxygenation via SAD. Include SAD size 1 to 4 and intubating SAD. Drawer 3, Plan C, face mask ventilation. Include face masks of different sizes, oropharyngeal airways of various sizes, nasopharyngeal airways of various sizes, SAD with orogastric drainage conduit. Drawer 4, Plan D, surgical airway. Include tracheostomy set, needle cricothyroidotomy, IV catheters, and jet ventilation device. Regarding rigid indirect laryngoscopes, these can be divided into non-guided devices, guided devices, and optical stylets. Examples of non-guided devices includes CMAC and glide scope, which provides an indirect view of larynx but require direction of tracheal tube towards the larynx. Guided devices provide indirect view and act as a conduit for passage of tracheal tube. Examples includes the bullet laryngoscope and AirTrack. Regarding optical stylets, these provide indirect view via rigid or semi-rigid stylet with a loaded tracheal tube for railroading. Example includes Bonfils, Brambrink, Shikani, and Lightwan. Regarding advantages and disadvantages of fiber optic bronchoscope. Advantages includes it is the gold standard for difficult airway management. It is the most versatile instrument. There is improved image quality with new scopes, increasing success rate. It is especially useful when decreased mouth opening is present. The LMA may be a useful adjunct in fiber optic bronchoscopy. This table shows the size compatibility of tracheal tubes, bronchoscopes, and LMAs. This picture shows the use of an LMA for difficult intubation. The guide wire is passed through the suction port of the fiber optic bronchoscope. An airway exchange catheter may be passed over the guide wire to assist for intubation as well. Disadvantages of fiber optic bronchoscope: optical problems with fogging, blood or secretions. It is non-intuitive. There is significant learning curve. It requires practice to acquire and maintain skills. It is expensive, fragile, and not always available. Next is air trap. Advantages includes it incorporates a lens warmer that prevents fogging. It is the only completely disposable single-use optical laryngoscope. It is inexpensive, portable, easy to set up, and well suited for non-operating room settings. Limitations includes best for oral intubation. Good mouth opening is required. There is learning curve. One can lose landmarks when attention is directed through the eyepiece. There is need for caution when insertion into the mouth. Sometimes it is difficult to pass a tracheal tube despite excellent view. Regarding light scope, advantages includes reusable video baton that slides into disposable plastic blades or handles. It is similar to Macintosh blade design. Warming at lens prevents fogging. Relatively portable, simple to set up, and intuitive to use. Limitations includes mouth opening is required. There is learning curve. Sometimes it is difficult to pass tracheal tube despite excellent view. Caution is required when inserting scope with styleted tubes. Lastly, we shall discuss summary of recommendations from Airway Management in Neonates and Infants, European Society of Anesthesiology and Intensive Care, BJA Joint Guidelines 2023. These practice guidelines were developed by International Task Force on behalf of SAIC and BJA, and the recommendations are limited to neonatal and infant population up to 1 year of age because these patients have been identified as the most vulnerable during airway management. PICO1 Preoperative Airway Assessment to predict difficulty. It is recommended to use medical history and physical examination to predict difficult airway management in neonates and infants. Physical risk factors for difficult airway in neonates and infants includes micro, retro or prognathia, limited mouth opening, facial asymmetry, fixed cervical spine, labial or palatine cleft, oral or neck mass. Other physical risk factors are included here, including causes for chronic obstruction such as tonsillar hypertrophy, glottic web, hemangioma, subglottic stenosis, causes for acute obstruction, infection, epiglottitis, retropharyngeal abscess, foreign body aspiration and trauma, causes for poor mouth opening or mobility of the jaw or neck, TMJ joint disease, spinal fusion, burns contractures, measles stomatitis. Various syndromes with difficult airway and airway implications are included here for completion. Although there are airway scoring systems such as the Colorado Pediatric Airway Score (COPUR), no studies prospectively evaluated the role of physical features in predicting difficult airway management in neonates and infants with an apparently normal airway, hence no normal values are available for neonates and infants. PICO2 Preparation for airway management and pharmacological treatment. It is recommended to use an adequate level of sedation or general anesthesia in neonates and infants during airway management to ensure patient comfort and safety. It is recommended to use neuromuscular block before tracheal intubation when maintaining spontaneous breathing is not necessary. Risks and benefits of neuromuscular blocker should be balanced for the individual patient and team skills. PICO3 Tracheal intubation. Is direct laryngoscopy or video laryngoscopy the first choice technique for tracheal intubation in neonates and infants? It is recommended to use video laryngoscopy with an age-adapted standard blade, Macintosh or Miller, as the first choice for tracheal intubation of neonates and infants, including tracheal intubation in the lateral position. Video laryngoscope should also be used for teaching purposes. Training is a mandatory and essential prerequisite for correct use of video laryngoscope. Use of video laryngoscope is warranted in anesthesia suites, intensive care units, and emergency departments. Next, should apneic oxygenation become standard of care during tracheal intubation? It is recommended to use apneic oxygenation during tracheal intubation in neonates. In infants, apneic oxygenation, low or high flow during tracheal intubation, should be based on risk of hypoxemia in the patient and the experience of the provider. Cuff or uncuffed tracheal tube as standard of care. Cuff and uncuffed tubes can both be safely used. Cuff tubes in children more than 3 kg. For the safe use of cuff tubes, it is recommended to adhere to the manufacturer's instructions, including size and cuff inflation pressure limits. Ensure minimal cuff pressure to avoid air leak, but not exceeding 20 to 30 cm H2O in general to reduce the risk of post-extubation stridor. Anatomical variation, clinical condition, and degree of prematurity may warrant the use of uncuffed tube. What is the definition of unanticipated difficult intubation in neonates and infants? The suggested definition of unanticipated difficult intubation in neonates and infants is 2 failed tracheal intubation attempts. Nasal or oral route for tracheal intubation in neonates and infants. Nasal route is often preferred for success rate in neonates and oral route for infants, but limited data are available to recommend the nasal or oral route. When nasal route is chosen, risk of bleeding and nose preparation with topical vasoconstrictors should be considered. Can a supraglottic airway device be an alternative to tracheal tube in difficult airway or emergency situations? It is recommended to use supraglottic airway device for rescue oxygenation and ventilation when tracheal intubation has failed or face mask ventilation is inadequate. Is a neonatal and infant tracheal intubation algorithm necessary? It is recommended to develop a multidisciplinary consensus-based tracheal intubation cognitive aid for neonates and infants to harmonize clinical practices and potentially reduce tracheal intubation-related morbidity and mortality to enable assessment of long-term outcomes. Examples of algorithms for difficult airway in neonates and infants includes that from Disma et al. In 2024. This algorithm is divided into 3 sections: preparation, intubation attempts, and emergency airway. During preparation, the local situation and expertise should be evaluated and a plan discussed with the team. Assessment of patient includes physical condition and medical history. Evaluation of local situation includes staff, including help and equipment. Once intubation attempts are started, the clinical conditions of the patient should be evaluated after every attempt. The patient may be clinically stable or clinically unstable. For clinically stable patient, options includes video laryngoscopy, stylet wire or bougie, hyperangulated blade and fiber optic scope. For clinically unstable patient, options includes face mask ventilation, supraglottic airway device for rescue oxygenation and ventilation, and use of video laryngoscopy. Consider neuromuscular blockade. Ensure adequate anesthesia. Limit attempts 3+1. The emergency pathway should be entered in the case of an unstable patient. Options includes to awake the patient, or preparation for advanced techniques such as rigid bronchoscopy, emergency front of neck access, or ECMO. After the incident, proceed with extubation plan and debrief. Every difficult case should be reviewed and discussed to learn from errors. This is another difficult airway algorithm for neonates and infants by Apfelbaum et al. In 2022, which is included here for completion. Additionally, for children 1 to 8 years old, the Difficult Airway Society has 3 algorithms. First, for difficult mask ventilation during routine induction of anesthesia. Secondly, for unanticipated difficult tracheal intubation during routine induction of anesthesia. And thirdly, cannot intubate and cannot ventilate algorithm in paralyzed anesthetized child aged 1 to 8 years old, which are included here for completion. PICO 4, Difficult Airway Management. What should be the gold standard for anticipated difficult airway management and who should be involved? For anticipated difficult airway management, at least one type of video laryngoscope, flexible intubating scope, or rigid or semi-rigid scope should be available, including appropriate sizes for patient age, in addition to routinely used equipments such as supraglottic airway devices and face mask. It is recommended to limit the number of tracheal intubation attempts by reassessing the clinical condition and by considering a change to a different technique, different provider, or both after each attempt. After 4 attempts, clinicians should consider aborting intubation attempts and waking the patient if feasible. There is insufficient evidence to recommend which patient should be intubated with hyperangulated blades. However, in cases where standard blades fail and airway is difficult, for example in anterior larynx, suspected cervical spine injury, or limited movement, the next step should be an alternative advanced technique, including use of hyperangulated blades with a stylet, flexible or rigid bronchoscopy, alone or in combination with videolaryngoscopy, or flexible bronchoscopy with a supraglottic airway device. It is recommended to use a stylet to reinforce and pre-shape tracheal tubes when hyperangulated laryngoscope blade is used, or when the larynx is anatomically anterior. Bougies of appropriate size can be used to facilitate a difficult intubation or to guide tube insertion. Routine use of stylet to improve success rate of tracheal intubation cannot be recommended when performing laryngoscopy with standard blades. Regarding bronchoscopy, it is recommended to use flexible bronchoscopy by the nasal route in case of restricted mouth opening. Flexible fiber optic tracheal intubation can be performed through a supraglottic airway device, a specially designed face mask, or via one nostril when a nasopharyngeal tube is in place in the other nostril for oxygenation. Intubation through a special face mask can be easier, especially for trainees or novices, and when performed via the nasal route. Another provider can assist with mask ventilation during intubation. If not using supraglottic airway device, trainees and novices may choose the nasal route for fiber optic intubation unless contraindicated under supervision of an expert. It is suggested to use rigid bronchoscope as an advanced technique when laryngeal inlet is obstructed by swelling and in cases of upper airway stenosis or compression, or in congenital or post-surgical tracheal constriction or tortuosity. If necessary, a multidisciplinary team, including otolaryngologists, should be involved. Regarding tracheostomy, after induction of GA, when tracheal intubation fails, oxygenation and ventilation via a supraglottic airway device or face mask are severely impaired or impossible, and spontaneous breathing cannot be restored, then a surgical tracheostomy should be performed. Of the several techniques described, evidence is lacking for superiority of one technique over another. Surgical cricothyroidotomy and percutaneous needle cricothyroidotomy are not suitable options in neonates and infants. For the former, because of small size of the cricothyroid membrane, will render insertion of tracheal tube impossible, and for the latter, due to unfavorable anatomy. When expertise and equipment are available, ECMO can be considered as a rescue intervention for difficult airway when waking the patient is not an option. However, there is lack of evidence to support such a recommendation. The decision for ECMO is left to local guidelines. There is no evidence available supporting or refuting management of difficult airways in a particular location, operating room or intensive care unit, if adequate expertise, equipments, and medications for managing unanticipated and anticipated difficult airways are available. PICO5, confirmation of tracheal intubation. It is recommended that immediate verification of successful intubation with both clinical assessment, bilateral and symmetrical breath sounds, and ETCO2 with sustained ETCO2 waveforms. In cases of difficult intubation or complex patients, use of videolaryngoscopy for a second look in combination with ETCO2 and ultrasonography should be considered to confirm successful tracheal intubation. It is suggested to verify optimal tracheal tube position in the tracheobronchial tree in cases of complex patients or those with continued clinical instability with chest radiography, visualization of carina with flexible fibroscope, chest ultrasound, or all. PICO6, strategies for tracheal extubation. What is the best strategy for safe extubation in neonates and infants after difficult intubation, either anticipated or unanticipated? It is suggested to assess clinical signs like conjugate gaze, facial grimace, eye opening, and purposeful movements to predict successful awake extubation. If measurable, a tidal volume of more than 5 mL per kg can support readiness to extubate. Equipment for reintubation should be immediately available at every tracheal extubation, especially in cases of difficult tracheal intubation or previous failed extubation. The specific airway pathology, anatomical reason for difficult intubation, for example airway swelling, and number of intubation attempts should be considered. It is suggested to use intraoperative corticosteroids, nebulized adrenaline, or both to prevent and treat post-extubation stridor when significant airway manipulation has occurred. It is recommended to use HFNO, CPAP, or nasal IPPV for post-extubation respiratory support when clinically appropriate. Next, should tracheal extubation or removal of airway device be performed under deep anesthesia or when the patient is awake? The decision to remove a supraglottic airway device or tracheal tube under deep anesthesia in neonates or infants to minimize overall airway complications should depend on the following factors. A. Experience of the anesthesiologist. B. Airway complications such as bronchospasm or laryngospasm at the induction of anesthesia or difficult or traumatic intubation or mass ventilation. C. Overall risk of airway complications and reactivity. For example, presence of airway infection, asthma, airway anomalies, masses, reduced pulmonary oxygen reserve, thoracoabdominal asynchrony, ventilatory frequency, conjugate gaze, pharyngeal tone, and high oxygen requirement. D. Presence or absence of other comorbidities and risk factors, such as cardiac, metabolic, sepsis, actual or former. E. Type of surgery, for example, maxillofacial or craniofacial, ENT, neurosurgery or plastic surgery, and type of anesthesia, TIVA or inhalational. F. Risk of pulmonary aspiration, for example, emergency surgery. G. Availability of resources and backup for ensuring overall safety of the child. H. Complete recovery from sedatives and neuromuscular blockers. This is an example of an extubation strategy published by Wetherall et al. In 2022. Situations and actions to be undertaken in cases of anticipated difficult extubation. Extubation is always an elective maneuver, and plan should be developed and discussed beforehand. Management of anticipated difficult extubation may be divided into preparation and extubation phase. For preparation phase, factors to consider includes where, when, who, and what. Regarding where, extubation in the most appropriate location, operating room or intensive care. When in doubt, transfer to operating room. Regarding when, daytime when possible. Regarding who, ensure presence of competent and experienced physician in pediatric difficult airway management. If high risk of failed extubation or history of advanced airway management, request ENT specialists or competent physician who are able to perform emergency front of neck access or surgical access to the trachea. Regarding what, have appropriate airway equipment available and ready to use for reintubation, have adequate respiratory support systems such as CPAP, oxygen nasal cannula, including high flow systems in case of risk of airway obstruction or desaturation. Optimize any reversible confounders that may complicate extubation, such as high FiO2 requirement, hypercapnia, acidosis, volume overload, hemodynamic instability, hypovolemia, anemia, neuromuscular blockade, and hypothermia. The extubation phase is divided into 3 wean and reverse, time out, and discharge sections. Wean and reverse from anesthesia, sedatives, and neuromuscular blockers. Time out. Inform the team about the extubation plan. Discharge. Have a clear strategy for post-anesthesia recovery in case of risk of secondary airway failure and obstruction. Human factors and pediatric airway competencies. Addressing human factors related errors and improving communication and teamwork might reduce patient harm. Common errors includes error in judgment, 43%, failure to check, 17%, Technical failures of skill 9%, inexperience 7%, inattention or distraction 5%, communication issues 5%. The most common mechanisms of error includes rule-based mistakes and latent system errors. Pediatric airway management requires a specific set of skills and structured training. Implementing and maintaining skills using neonatal intubation simulation training is advised when exposure during neonatal practice is not frequent enough. Additionally, for children 1 to 8 years old, DAS algorithm for difficult mask ventilation during routine induction of anesthesia in child age 1 to 8 years. When difficult mask ventilation is encountered, give 100% oxygen and call for help. 3 steps. Step A, optimize head position. Step B, insertion of oropharyngeal airway. And Step C, second line, insertion of supraglottic airway device. Step A, optimize head position. Consider adjusting chin lift and jaw thrust. Insertion of shoulder roll if less than 2 years old. Neutral head position if more than 2 years old. Adjust cricoid pressure if used. Ventilating using 2-person back mask technique. Check equipment. Consider changing circuit mask or connectors. If equipment failure is suspected, change to self-inflating bag and isolate from anesthetic machine promptly. Check depth of anesthesia. Consider deepening anesthesia and use of CPAP. Step B, insertion of oropharyngeal airway. Call for help again if not arrived. Assess for cause of difficult mask ventilation, such as light anesthesia, laryngospasm, and gastric distension. Pass OG or NG tube. Maintain anesthesia, maintain CPAP, deepen anesthesia, propofol first line. If relaxant is given, intubate. If intubation not successful, go to unanticipated difficult tracheal intubation algorithm. Step C, second line, insertion of supraglottic airway device. Not more than 3 attempts, consider nasopharyngeal airway, release of cricoid pressure. If good airway, continue. If good airway not achieved, assess SpO2. If SpO2 more than 80%, consider SAD malposition or blockage, equipment malfunction, bronchospasm, or pneumothorax. Consider waking up the patient. If SpO2 less than 80%, attempt intubation and consider paralysis. If succeed, proceed. If fail, go to scenario of CICV. Next, DAS algorithm. Unanticipated difficult tracheal intubation during routine induction of anesthesia in a child age 1 to 8 years old. If difficult direct laryngoscopy is encountered, give 100% oxygen and maintain anesthesia and call for help. There are 2 sections. Step A, initial tracheal intubation plan when mask ventilation is satisfactory, and Step B, secondary tracheal intubation plan. Step A, initial tracheal intubation plan when mask ventilation is satisfactory. Ensure oxygenation, anesthesia, CPAP, and management of gastric distension with OG or NG tube. Direct laryngoscopy, not more than 4 attempts. Check neck flexion and head extension. Laryngoscopy technique. External laryngeal manipulation, remove or adjust. Vocal cords open and immobile. Ensure adequate paralysis. If poor view, consider bougie, straight blade laryngoscope, and or smaller ETT. If successful intubation, verify ETT position with capnography, visual confirmation and auscultation. If ETT is too small, consider using throat pack and tie to ETT. If in doubt, take ETT out. If failed intubation, however with good oxygenation, proceed with Step B, secondary tracheal intubation plan. Call for help again if not arrived. Insertion of SAD, not more than 3 attempts. Oxygenate and ventilate. Consider increasing size of SAD once if ventilation is inadequate. If successful, consider modifying anesthesia and surgery plan. Assess safety of proceeding with surgery using a supraglottic airway device. If unsafe, postpone surgery and wake up the patient. If safe, proceed with surgery. Consider 1 attempt at FOI via SAD. Verify intubation and leave SAD in place and proceed with surgery. If failed intubation via SAD, consider postponing the surgery and waking the patient up. If failed oxygenation, SpO2 less than 90% with FiO2 1, convert to face mask, optimize head position, oxygenate and ventilate. Ventilate using 2-person back mask technique. CPAP and oral or nasopharyngeal airway. Manage gastric distension with OG or NG tube. Reverse non-depolarizing muscle relaxant. If successful, postpone surgery and wake patient up. If failed ventilation and oxygenation, go to scenario of CICV. Following intubation attempts, consider trauma to the airway and extubation in controlled setting. CICV in a paralyzed anesthetized child, age 1 to 8 years old, thus guidelines. Failed intubation and inadequate ventilation, give FiO2 1 and call for help. There are 3 steps. Step A, continue to attempt oxygenation and ventilation. Step B, attempt to wake up if maintaining SpO2 more than 80%. Step C, airway rescue techniques for CICV in SpO2 less than 80% and falling and/or heart rate decreasing. Step A, continue to attempt oxygenation and ventilation with FiO2 1, optimize head position, chin lift and jaw thrust, insertion of oropharyngeal airway or SAD, ventilate using 2-person back mask technique, manage gastric distension with OG or NG tube. Step B, attempt wake up if maintaining SpO2 more than 80%. If rocuronium or vecuronium use, consider Sugammadex 16 mg per kg for full reversal. Prepare for rescue techniques in case child deteriorates. Step C, airway rescue techniques for CICV. Call for help again if not arrive. Call for specialist ENT assistance. If ENT available, consider surgical tracheostomy, rigid bronchoscopy with ventilation or jet ventilation, pressure limited. If ENT not available, percutaneous cannula cricothyroidotomy or transtracheal jet ventilation. If successful, continue jet ventilation set to lowest delivery pressure until wake up or definitive airway established. If failed, perform surgical cricothyroidotomy or transtracheal and insertion of endotracheal tube or tracheostomy tube. Consider passive oxygen insufflation while preparing. Note that cricothyroidotomy techniques can have serious complications and training is required. Only use in life-threatening situations and convert to definitive airway as soon as possible. Steps for cannula cricothyroidotomy: extend the neck with shoulder roll, stabilize larynx with non-dominant hand, access the cricothyroid membrane with a dedicated 14 or 16 gauge cannula, aim in caudate direction, confirm position by air aspiration using a syringe with saline, connect to either adjustable pressure limiting device set to lowest delivery pressure, or 4-bar oxygen source with flow meter and Y connector, match the flow in liters per minute to the child's age. Cautiously increase inflation pressure or flow rate to achieve adequate chest expansion. Wait for full expiration before the next inflation. Maintain upper airway patency to aid expiration. Technique for surgical cricothyroidotomy. Step 1. Position the patient so that the neck is fully extended, so that the trachea and larynx are pushed forward. Locate the cricothyroid membrane and stabilize the trachea. Step 3. With a scalpel blade, make a step incision through the skin and cricothyroid membrane. Arterial forceps, scalpel blade, and tracheal dilators may be used to dilate the orifice. Step 4. Insert a tracheal hook or retractor at the lower edge of the incision. Step 5. Place an appropriately sized tracheal or tracheostomy tube. Step 6. Ventilate the patient and assess for effectiveness. Step 7. Secure the tube. These are my references. Thank you.